Colorado's Medical Orders for Scope of Treatment, known as MOST, is a way for patients to consider and document treatment preferences, ensuring their wishes are followed. MOST is a variant of Physician's Orders for Life-Sustaining Treatment, or POLST, that was pioneered in Oregon in the late 1990s. Similar programs are sanctioned in many states or are in development in all but a handful of states. Extensive research shows the Medical Orders for Scope of Treatment program greatly improves utilization of advanced care planning and adherence to expressed wishes. The Medical Orders for Scope of Treatment program is spearheaded by the Colorado Advanced Directives Consortium, a volunteer organization of professionals in healthcare, senior services, law, and ethics, dedicated to improving the tools and processes for healthcare decision-making in Colorado. The program became law after being passed by the Colorado legislature in 2010. The form was revised in April 2015 based on feedback provided during its early years of use and in concert with dynamics in the national POLST movement. Hi, my name is Dr. Don Murphy. I'm a geriatrician with Rocky Mountain Senior Care. I've been talking with seniors and their family members about advanced care planning for about 30 to 35 years, and I thought I would share some of that experience and ideas with you today. Why should someone have a discussion about their end-of-life care and specifically have a MOST form? The key reason is that this is our best chance, our best tool to help reflect their preferences. And although many people have similar preferences, a number of people have very unique preferences. And it's only in the discussion when that individual is cognitively intact and not acutely ill and that they can express their wishes to their loved ones, their family, significant others, that's really their best chance to help lay out what they would like their future to look like with regard to end-of-life care.
As physicians, we take an oath, and it's first do no harm. And I think that's the mantra of all healthcare providers. But we also need to consider that sometimes this can be interpreted as do everything. And while physicians and providers can sustain life, we can't ensure that a patient has the same quality of life. And it's very important for the patient to really determine that and make an informed decision about what's going to be in their best interest.
Making a decision about end of life is a personal choice.
Why doesn't the doctor just decide the treatment? Well, there's a long history going back to the 1950s, and basically in our culture, in our healthcare system, we decided that we would move away from what we call paternalism, where the doctor kind of decides what's right for the patient. And this applies to all kinds of things. But we pretty much got rid of paternalism back in the 50s and 60s. And ever since then, we've been doing our best to reflect what the patient wants as individualized care. There are some cases where one could argue that it's best for not the doctor, but the healthcare team. That is, all professionals who care for this individual patient when he or she cannot make decisions on his own or might have no significant others to make those decisions. That's a debate that has been playing out for the last 20 or so years. There's actually a lot of progress that's being made in that area here in Colorado and other states as well. But for the most part, when an individual patient can express preferences, we all want those preferences to be known by close ones to that patient.
MOST was essentially derived for the elderly population as well as those that are chronically ill with frequent hospitalizations. However, I think everyone should be aware of what MOST is and what it stands for, and essentially it's beneficial for everyone.
The good thing about the MOST form is that it's very clear, simply stated. There's a lot of information that has been condensed so that reading it and making a decision is very powerful.
Everybody in EMS knows paperwork, paperwork, paperwork. Nobody likes paperwork. And unfortunately, the most form is one more paperwork that you're going to have to look at. However, because of the simplicity of the form, it's actually going to make your job a whole lot easier.
So most has really affected the way that I practice medicine by enabling me to have shared decision making now with patients and families. It's very encouraging as a physician to know that I'm doing what specifically the patient wants and what the patient thinks is in their best interest.
Death is scary for a lot of people. There are unknowns and people get really emotional about it. Some people don't want to talk about it. But the most form helps to frame the discussion and helps people to come to a decision in order to have the most comfortable experience with their transitioning from life to death.
When do I bring up the discussion or advanced care directives in general, or more specifically the most form? It all depends on the setting and the time I have. Now, again, in the ideal world, I would cover it with every patient when I first meet them. We don't live in the ideal world. We in primary care have to deal with all kinds of things, so I kind of make a judgment, gee, do we have time to cover this or not? If we don't on that first visit, I know that somewhere down the road, either I or one of my colleagues needs to cover this. A lot of primary care now is moving towards team-based care. It's a good thing, but someone on the team needs to cover this discussion.
Usually I'm able to talk with patients about what a most form is, and also even in the most dire circumstances, it's something that I'll bring up and can bring up very easily with patients and families, because it's something that's going through their heads at that moment.
We use the most form on the first day of our admissions for people who are entering hospice, and that is a time when we can get specific decisions that they want, and at that time we're able to explain different options, for example.
It's unique as an emergency physician, the way that most affects our practice. And when I see a patient initially, I will ask either the EMS providers or the patient or the family if they have a most form, if they know what it is and what it stands for.
So some wonder if the most is mandatory. The answer is no. The legislation was set up to say we ought to educate and can use it when it's appropriate, but it's not mandatory.
So when I have patients or families that tell me that I'm not ready to do this right now, I really try to respect their feelings in the moment. Because at that time, in the emergency setting, they really may not be able to do it at that point. I want them to know, however, that it's available and that it's something that we'll need to readdress. I try to make sure that the admitting physician knows that we have not been able to discuss this at this time, but it's something that they need to bring up after, some of the emotions, the heightened emotions from the emergency setting have calmed down and people can have some time to think through this. Really, letting nature take its course is not always in the best interest for the patient or their families, and I try to really encourage patients and families to be more proactive than reactive.
The most form allows a patient to have their wishes followed by the medical community, by their loved ones, by anyone who's involved in their care without argument or confusion, allowing for the caregiver to rest at ease and knowing that they're doing what the patient desires.
Why is it important to include someone besides the individual patient in this discussion? Two reasons. One is that we really do want to be sharing our preferences with our loved ones. If we don't, there's a good chance or a higher chance that those preferences might not be respected. So we should be having these discussions anyway. And the second is that in involving close, people who are close to us, say family, for example, it helps prepare them, the family members, for something that I, the individual patient, have been well prepared for example. And I can just tell you, after years of doing this, I find the discussions that involve the family members or significant others much more enlightening and fruitful than the individual patients. Because you pretty much know what many individual patients will say. What you don't know is how it's going to play out when they're expressing these preferences in the context of a family or group of close friends.
Yes, absolutely, the doctor has to follow the most, and that is an issue that comes up at times with family members who aren't routinely involved in the patient's care or who have other ideas of what the patient may or may not want. We stick with what is on the most form. Of course, we talk to families and we talk to the patients to make sure that they still agree with what is on that form, but ultimately, the reason that we have most forms is for doctors and healthcare providers to follow what is listed as their wishes for treatment.
The most form is easy to fill out, yet very powerful in the decisions that are made by filling it out.
One of the reasons that I like the most form so much is because as soon as it is given to me by paramedics or family or the patient themselves, I know immediately what is going to be an option for their care, even in very emergent circumstances.
I can tell you what I really like about our Colorado Most form is it summarizes the three key things, three key scenarios and decisions that I have been encouraging patients and their families to think about for decades. So it is a great summary of the preferences, and I know that, I knew 30 years ago, I know today, that we can't, nor should we, cover every scenario that comes up. But when you cover the scenarios that come up in the Most form, basically the same ones I've covered in clinical care for years, you know that you have a good profile. You can be rest assured that you have a pretty good idea of where that individual falls on their preferences. People do need to fill out the demographic corner in full, and then we go to the three main sections. The first one is on CPR. So that's how I open my discussions anyway. I talk about what happens when someone has a cardiac arrest. They stop breathing, their heart stops beating, they fall down, they're dead. And the only thing that can help someone recover, short of dislodging the hot dog at a picnic, is cardiopulmonary resuscitation. We go through a brief discussion of what that involves. Most patients and their families already know that. Further, I explain the likelihood that CPR will help them or not. And that's pretty important for patients to make that decision. So we cover that, yes or no.
I don't believe people are necessarily aware of the trauma and invasiveness of CPR. A lot of the images they have could be from movies and TV shows, which do not portray an accurate picture.
CPR is really an all or nothing sort of treatment. You're either going to respond to it or you're not. However, once you are resuscitated, it does not mean that you will be who you were before. You may have a pulse and you may be breathing, but you may not immediately return to your same quality of life that you had prior to your arrest and CPR. And it's very important for patients to understand that. It's not something that we take lightly. It's not something that we just try and see if it works. It's an all-in type of treatment.
If you are one of the 15–20% of seniors who say, by no means do I want to have CPR, and you live in the community, by the way, that percentage is much higher when you're looking at seniors in nursing homes with dementia and everything else, then it's much, much higher. But the point is that if you're living in community and you want your wishes to be respected, you cannot feel confident that just having this will guarantee that. So if you're darn sure you don't want CPR, you ought to think about getting a do not resuscitate bracelet or necklace.
First thing when I pull up on scene is I go inside and I check the patient's wrist, whether they have a bracelet or a pendant on. Then if they don't, I go to the fridge is my next step to see if there's anything hanging on the fridge that will provide that documentation and information for me on where I'm going to proceed next. So when you show up on scene and you're either provided the most or you find the most hanging on the fridge and it tells you that no CPR is required or the patient does not want CPR to be done, the best thing you can do is make sure that patient is as comfortable as they can be regarding the situation. Make sure that everything is decent. Make sure your patient isn't laying on the floor, sprawled out to where if this is your family member, how would you want them to be laid out on the floor and presented to the next family that's going to show up on scene.
Recognize that on the MOST form, there are different options for treatment. However, it is important to understand that comfort care will always be provided to the patients. That's just a means of saying that we will always make sure that the patient is as comfortable as possible and that any other additional treatments would be additional to that, but that would be the underlying base of their care. So moving on to Section B, this delineates the medical interventions that the patient would want. Full treatment is where the primary goal is to prolong life by all medically effective means. So this would include intubation, mechanical ventilation, cardioversion when indicated, including intensive care and transfer to a hospital. Selective treatment is the goal to treat medical conditions while avoiding burdensome measures. So in this case, you could use IV antibiotics, you could use IV fluids, but you would want to avoid intubation and mechanical ventilation. Transfer to a hospital if indicated, but try to avoid intensive care. And finally, comfort-focused treatment, where the primary goal is to maximize comfort. This is to relieve pain and suffering with medication by any route as needed. And do not transfer to the hospital for life-sustaining treatment unless the goals of comfort care cannot be accomplished in their current situation.
So I've indicated that the MOST form is an excellent summary of preferences. However, with a lot of experience with the MOST forms, we found that there can be some inconsistencies and some notations that for a particular patient raise questions that have to be explored more. One of the inconsistencies that was found over the last several years was that people could indicate yes CPR in Section A, but then in Section B, they would put selective treatment or comfort-focused treatment. That's inconsistent. That tells me is that the patient did not understand fully about CPR. CPR implies you're going to get the most aggressive treatment we have in modern medicine. It will involve intensive care. There's no way around that. So that if they do have yes CPR, they also have to have full treatment.
Often I think patients and individuals have misconceptions about what resuscitation is and what CPR is. And they think that CPR can be separated from ventilation and breathing, and it is difficult at times, particularly in emergency settings, to really explain that in detail. And that's something, though, I think that the MOST form has been quite helpful with in terms of delineating between those two and trying to explain in detail, again, in common language that patients can understand and not just based on what they've seen in the media or on television. So make sure the patient understands that if they choose yes CPR, they must choose yes to full treatment in Section B. This involves the use of intubation and ventilatory support for the patient to aid in their treatment. It includes mechanical ventilation, it includes cardioversion as indicated, and it would include admission to an intensive care. So selective treatment, in addition to comfort care treatment, would be use of IV antibiotics, IV fluids. However, the patient would not be intubated and mechanical ventilation is not supported. They may use something called non-invasive positive airway pressure, which is, again, not intubation, but a mechanical means of supporting the patient's breathing. This particular selection of treatment would avoid intensive care. And then finally, in medical interventions, there's the comfort-focused treatment option, which is to relieve pain and suffering by medication by any route as needed. The goal being do not transfer for any life-sustaining treatment, and transfer only if those needs cannot be met in the patient's current location.
I ask the person to imagine that, let's say you get real short of breath some evening, and the facility or your family gets you to the emergency room. The doctors there find that you have a real bad pneumonia, so bad that unless they get you certain treatments, chances are you may die from that pneumonia. And so those treatments would be a mechanical ventilation, that is putting them on a breathing machine in the intensive care unit. Let's say for a couple of days, they're going to treat you with all kinds of other things. But the point here is to ask, would you want those fairly aggressive measures if you had a reasonable chance of recovering? And in this case, I say maybe a 50-50 chance. It's unlike CPR, where the odds of recovery, depending on your comorbid illnesses, is very low. In this case, we're saying, okay, you at least have a 50% chance of recovering and getting back to how you are right now. Would you want that? Again, most seniors who are otherwise healthy are going to say yes. Then I ask, would you like prolonged intensive care, say a week or two, when things are going poorly? You're not getting better. Everything is going wrong. Almost every senior at that point says, no, I don't want those prolonged efforts. So what I've already ferreted out in the first two things is, do you fall into this camp that says, well, if there's a chance of helping me and getting me better, even though the chances aren't great, go ahead and go for it. Just don't get carried away. You know, if I'm in the ICU for a week, a couple of weeks, don't keep going on. But that's what most healthy seniors would say. Then you have the 15–20% that say, no, don't do any of that. And they're the ones we really want to find out to get the most forms filled out, because even if someone over in this first group, the 80–85% who would want aggressive measures, regardless of the likelihood of benefit, they're going to get that anyway, whether they have a most form or not. The people over here, the 15% that absolutely don't want the aggressive things, they're going to get the aggressive things unless they've made it clear through a most form, their families and all that, what their preferences are.
The next section, Section C, addresses artificially administered nutrition. The options there are either long-term placement, permanent artificial nutrition versus temporary artificial nutrition versus no artificial nutrition by tube.
The third scenario I ask is, imagine 10 years from now, you're in a nursing home, you have dementia for whatever reason, you're at a point where you don't recognize anyone, you're either chair or bed bound, and you're getting to a point where swallowing is difficult and unsafe. Would you at that point want a feeding tube that goes through your abdominal wall and provides fluid and nutrition through the feeding tube? I would say 95% of seniors easily would say no thank you. People just don't want that. The very few percentage that do say yes to that base it on their perceptions of their faith tradition. No one says, oh gee, Dr. Murphy, I'd like to have that because that's what I envision as good quality of life when I get to that point. But there are a few people that say, well, my pastor, my rabbi, my so-and-so believe that this is what I should have, therefore they say yes to that. I can't think of an exception of someone who would say yes to long-term tube feeding when they have advanced dementia without that faith perspective tied in there. So that then is part C of artificial nutrition. Now, on the most form, it gets a little more sophisticated than that. You can opt for temporary artificial nutrition. And I don't typically cover all that because that gets pretty tricky. What I do when I do have time and I sense that someone is leaning towards artificial nutrition temporarily, I explain that yes, we can do that from a medical, legal, ethical, any kind of perspective. Yes, we can do it temporarily. What's hard though is that once they start down that track, it's hard for the families or even the caregivers in a nursing home to pull back. It really is. It's just a very uncomfortable situation they put their family members in to say, here, let's start this for a month to see if. Now, this part, temporary nutrition, does come into play in people who have had strokes. They lose their ability to swallow, hopefully temporarily, and they may be able to regain it. So there are some special circumstances where this applies. But for the most part, this C section, artificially administered nutrition, we're capturing what that senior imagines really down the road, when a bunch of things could happen that would lead them to the point where they can't safely nourish themselves.
Ultimately, the MOST form should be looked at as a tool for encouraging discussion among healthcare providers and their family regarding end-of-life wishes and treatment options.
Between CPR, between the medical interventions, which includes full treatment, selective treatment, and comfort care, and then C, artificially administered nutrition, you have a profile that really tells you what to do. And these do not go into all the different specific clinical examples that could come up, not even close. But these profiles really provide excellent guidance as to what to do no matter what might come up.
And then the final section is just a documentation of the discussion with all who was present during the discussion, including the patient, their medical power of attorney, any legal proxy or other. And then finally, probably the most important section is the signature section by both the patient and the healthcare providers. The back of the MOST form provides additional information for healthcare professionals, including the patient's healthcare professional who helped prepare this form, the patient's primary contact, and other applicable information that could be essential if there are any questions regarding the form itself.
So let's assume that the MOST form has been completely covered. Should we be reviewing that, revisiting those decisions down the road? The answer is yes. I can't tell you with what frequency, it all depends on the patient and the circumstances, but if someone, for example, on their MOST form expressed a desire for aggressive care when they're, say, 80 years old and otherwise healthy, we ought to be revisiting that if indeed 2 years down the road they've had a series of strokes or whatever else and they're more impaired and they might not have those same preferences then. So yeah, I don't want to say you ought to be reviewing these once a year, but it is something that periodically we, the healthcare professionals, ought to keep in mind, patient and patient's family, particularly if in an earlier version they had expressed a desire for aggressive care. Now, I can tell you if someone has said, no, I don't want anything, they've made it very clear, I don't want CPR, I don't want aggressive care, I want comfort measures when the time comes, yes, it's appropriate to review that down the road, but it's rare that you would see someone change their focus on that. So one would wonder, okay, do we have to ask about other advanced directives, should we, when we're going through the MOST form? I have two responses to that. One is that I want to respect the discussions, the paperwork, the tools that people have used, and if they've gone through the time of doing that, we should know about them. But the second is that I feel that this captures really 98% of what we need to know. So when I ask patients about advanced directives, I mention the term, for example, living will, so that it reminds them kind of what we're talking about. But even if they say, oh yes, I've covered that, I have a living will, I said, well, hold on, wait a minute. No, we really haven't covered that, because the living will does not cover the scenarios that are likely to happen. Let's review again those things that we really do need to cover, and again, we can summarize those in the MOST form. A number of clinicians are starting to use the new Medicare billing code that carves out time and good payment, appropriate payment, for these discussions around advanced care planning.
EMS providers are more accustomed to the bright green form. However, you will see other documentations that are white. However, they are still valid forms and you can still go by those.
Some people assume that the most form has to be the original, that is the original green copy. It does not. We rely on the green ones a lot because they're recognizable, but a copy, any color, as long as it's, you can read it, suffices as a legitimate most form. Again, I have found this to be a good tool, even if it's administered by someone who doesn't have a lot of experience. It's helpful for me to see the latest version of the most form, because we will find specifics about that where we go, oh, wait a minute, that may have made sense for this patient 5 years ago, not so sure about now, let's revisit it.
A lot of times when you get on scene, family members are going to want you to provide other care that may or may not be on that most form. It is a legal document that you have to go by, and that is going to be your main concern by your patient's wishes, not your family member's wishes. As long as the most form is very clear for you to understand, your patient demographics are clear enough, and the signatures are on there, that is your main concern of what you're going to go with, and you're going to make sure your patient's concerns are top priority for you. So bringing the patient into the hospital or the emergency room, when you hand off to the doctor or the registered nurse who's going to take over for you, one of the first things that you want to give is that most, so that they're aware of the next steps that the patient is requesting.
I like to let them know that it's okay to have reservations and fear around a discussion about end of life, but it's better to have the discussion while you are in a state of mind that is more calm and the person who is dying is coherent. It might be possible later on that the person is not able to make a decision. So it's important to discuss the end-of-life treatments as soon as the question arises, so that we don't wait too late until the person is at that point and perhaps can't make a decision because they're incoherent.
You don't work differently since the passage of the MOST program. You still provide the level of care that you're trained to do, and make sure at the same time honoring the wishes that are on the MOST.
MOST has changed the final hours, minutes of patients and families. I think in a lot of ways it provides an expected outcome. It allows patients and families to have at times a sense of closure and increased acceptance from the families. It really treats the patients with the dignity and the respect that they deserve. And I think that that's something that is appreciated by everyone involved, including the healthcare providers.
The MOST form makes my job easier because it lays out all the choices that a person could have, and it helps me to explain how to transition from life to death in a most peaceful way.
I would strongly encourage anyone to use this form who works as a healthcare provider, and encourage their patients to use it.